You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri, and I'm your host, Dr. Jay Portnoy. It consists of a series of presentations by experts in allergy immunology and can serve as the didactic curriculum for trainees in the field. I hope you enjoy COLA.
Well, we are at 10 o'clock. If you don't mind, I'll do a quick introduction, then we'll let you get started. Good morning, everybody. This is Chris Miller coming to you from Conferences Online in Allergy. Today is September 12th. It's a Monday. A beautiful fall weather starting to set in here in town. Today, we have Dr. Gary Salzman, who is a professor of internal medicine and a pulmonologist at University Health here in Kansas City. Dr. Salzman has been gracious enough through the entire COLA years to present to us on primarily pulmonary function testing. Today he's going to be talking to us about the asthma-COPD overlap. So thanks, Dr. Salzman, for being here.
Great, thank you. So we're going to talk about asthma-COPD overlap, which has been getting more and more attention lately. I have no disclosures. So this is not anything new. This goes back to the 60s in the Netherlands, where they talked about the Dutch hypotheses, basically that bronchitis and asthma may be found in one patient at the same age, but as a rule there's a fluent development from bronchitis in youth to a more asthmatic picture in adults, which turns into a bronchitis of elderly patients. So this has been along since the 60s in terms of this overlap with asthma and COPD. And then molecular biology kind of supports this in terms of overlapping pathways between the two diseases and some genetic associations. And so there is some evidence that the two diseases have a lot in common, and certainly we're seeing more and more patients that have more of an overlaps presentation as opposed to one or the other of these diseases. So the pathways really are two different kind of phenotypes. One is a patient starts off having childhood allergic asthma that results in reduced lung function. And then they start smoking, and then that leads to worsening lung function in COPD. And so it may be that just the fact that someone's had asthma as a child reduces their lung function enough that when they do start smoking, even more reduction in lung function brings about significant COPD. And then the other kind of pathway is a lifelong smoker, a patient with COPD, pretty classical COPD, and then for some reason has a late onset feature of eosinophilic inflammation and airway reversibility, more like asthma. And so that's kind of a different pathway. And there's obviously some Th1 inflammation COPD and Th2 in asthma. So, but it's heterogeneous. I mean, we have basically eosinophilic COPD versus smoking asthmatics. Some may have more characteristics of COPD and more characteristics of asthma. Therapy is usually directed at the predominant phenotype, but in all these patients, you must include anti-inflammatory therapy. Bronchodilators alone are not effective. In COPD alone, bronchodilators can be effective, and we don't always use anti-inflammatory therapy. But in this overlap asthma-COPD, the treatment really needs to include an anti-inflammatory therapy. So one of the things that we do see in asthma is airway remodeling. We see inflammation that over time, without being treated adequately, leads to airway remodeling. And we know that patients that have long-term asthma that never use anti-inflammatories, only use bronchodilators, over time they'll get these airway remodeling and fixed airflow obstruction, and then will appear to be someone that has COPD and irreversible airflow obstruction, even though they've never smoked. Because of the airway remodeling, and that could be another mechanism for this asthma-COPD overlap, where it starts with asthma, untreated inflammation, ends up with airway remodeling, and then fixed airflow obstruction, and then more characteristic of COPD in later years, whereas when they were younger, it was more consistent with asthma. So the spectrum of COPD and asthma, there's really a lot of overlap. If we've got the big square of airflow obstruction, and then we have within that asthma, emphysema, chronic bronchitis, and then COPD is kind of in the middle there. And so you see that there is some overlap between airway obstruction, asthma, COPD. And so there is certainly overlap when we talk about these diseases. So this is an interesting statement from the American Thoracic Society in that it may be impossible to differentiate patients with asthma whose airflow obstruction does not remit completely from persons with chronic bronchitis and emphysema with partially reversible airflow obstruction and bronchial hyperresponsiveness. So wouldn't it be really easy if all patients with asthma demonstrated bronchial hyperreactivity on PFTs, whereas no patients with COPD demonstrated bronchial hyperreactivity? And unfortunately, that's not the case. It's not that easy. In asthma, as you probably know, that a significant number of patients with asthma don't demonstrate airway reactivity, particularly if they're sitting in a PFT lab or the office and their disease isn't triggered by anything. They may have completely normal PFTs with no hyperresponsiveness. And then there are a certain group of COPD patients, probably up to about 20% of COPD patients, who truly have bronchial hyperresponsiveness, that they meet the criteria for airway reactivity during PFT. So there certainly is, it's not as simple as asthma only has reactivity and nobody with COPD has reactivity. So in terms of trying to differentiate asthma and COPD, which I do think is important to do, because your goals of treatment are going to be quite different in terms of the two diseases. In asthma, our goal is, to have the patient no symptoms, full exercise tolerance, very rare exacerbations, and rare use of bronchodilators, like less than twice a week. COPD, our goals are a little bit different. The goals are going to be reduce exacerbations, improve symptoms, but these patients are not going to be able to be asymptomatic, are not going to have normal function, and so the goals are quite different. So it does make some difference to try to differentiate it, but none of these things are 100%. So asthma usually is early in life, often in childhood, but sometimes it can present later. COPD usually later in life, midlife, after a long history of smoking. Asthma is mainly immunological stimuli or family history of asthma, whereas COPD is almost exclusively cigarette smoking or exposure to other risk factors. Exposure to wood smoke is also a cause of COPD, and I do see quite a few women from third world countries who have developed COPD from wood smoke, from cooking, from heating their residence with wood burning fires, and developed COPD. Interestingly, in these wood smoke COPD patients, 100% of them, in my experience, have all been women, and no men from these countries have it, because the women are responsible for maintaining the fires. Asthma is usually intermittent, or if COPD is chronic and progressive. Again, we talked about reversibility. Asthma is largely reversible. COPD can be partially or fully reversible in certain patients. Asthma, they have episodic wheezing, chest tightness, dyspnea, cough. Where COPD, they're going to have more sputum production and a progressive, persistent or worsening shortness of breath. And of course, the inflammatory mediator is different. In terms of asthma, we're talking about eosinophils. In COPD, we're talking about neutrophils. So what's the definition of ACO? And this is that asthma COPD overlap. This has been controversial, and it's really not generally accepted, but this is one definition that has been proposed. It's the presence of chronic airflow limitation in a smoker or ex-smoker, greater than 35 years old, ratios less than 70%, and at least a 10-year history of smoking. They should have either a current diagnosis of asthma with post-bronchodilator treatment greater than 12% and 400, with a clinical history or family history, or a very positive bronchodilator response without a diagnosis of asthma, like 15% improvement post-bronchodilator and 400 cc improvement in FEV1, or the presence of eosinophilia in the blood. It's been talked about 300, greater than 300 eosinophils. Some people will use 150, but this is kind of the proposed definition. I don't think it's finalized yet, and there's still some controversy about how to diagnose these patients with asthma-COPD overlap syndrome. So the whole thing was cigarette smoking, and that's important to this diagnosis, and that all these patients would be smokers, or at least former smokers. And that cigarette smoke, not everybody is susceptible. So some patients are smokers, but their decrease in FEV1 will follow the same curve as the normal aging curve. As people get older, they're going to lose lung function at this rate. Either they're never smoked or they're not susceptible to cigarette smoke. The yellow line indicates a smoker that continues to smoke. And then, as you can see, disability starts here, and then death here from COPD. If they stop smoking at age 45, they can certainly prevent the rapid decline in lung function and even prevent disability and death. Even if they stop smoking here at 65, they can still prolong their life. So smoking cessation is still appropriate even at more severe disease, and even at older ages, it will make a difference. So definition of COPD is a disease state characterized by airflow limitation that's not fully reversible. And so by that is that they may have some reversibility on PFTs, but their airflow limitation is not going to be go up and down like it is in asthma. They will usually have progressive decrease in FEV1. The FEV1 FVC ratio will generally be less than 70%. And so those patients are generally going to show obstruction every time you check their lung function. It's progressive, associated with an abnormal inflammatory response of the lungs to noxious particles or gases, mainly cigarette smoke. So who should you consider with COPD? So obviously smoking history, at least 10 to 20 pack years, chronic cough with or without sputum, shortness of breath, onset of respiratory symptoms usually in their 40s, but have people that start smoking when they're 12, and they may start having symptoms in their 30s. Respiratory infections that persist or recur. So those are all the things that would suspect someone has COPD and that you'd want to get a pulmonary function test. And then, so spirometry is important. Generally, a ratio of less than 70%. You can get an accelerated decline in FEV1. We use spirometry, obviously, to screen people to try to identify it early so that we can make the diagnosis early. So in COPD, we often have hyperinflation, and this is hyperinflation on the chest x-ray. As you can see, low flattened diaphragms. On the lateral, you see an increased anterior-posterior diameter, and so this would be the hyperinflation that you would see with COPD and emphysema. So diagnosis based on risk factors, age, symptoms, persistent airflow obstruction, a low postbronchodilate FEV1, and a lower ratio. So prevalence, probably about 20 million people with COPD in the US, but we only diagnose about half of them. About half out there are undiagnosed. And so we have to increase our use of pulmonary function tests to try to diagnose these undiagnosed, or sometimes they're not diagnosed until they come into the hospital and already having a severe exacerbation. So we would like to try to get earlier diagnosis of these patients with COPD. So good prognosis is the younger age, people that quit smoking, higher FEV1, and the ones that have a marked reversibility of airway obstruction have better prognosis. So that would include the asthma COPD overlap patients have a better prognosis than patients with just COPD. Bad prognosis in COPD, older age, they already start demonstrating hypercapnia, hypoxemia, they're tachycardic at rest, they're short of breath at rest. So those are more of the poor prognosis for COPD, and these are more of the good prognosis for COPD. So in emphysema, that kind of the classic different types of is emphysema, or more the pink puffer. The patient's short of breath all the time, but it's not hypoxic. And the shortness of breath is mainly due to hyperinflation and stimulation of stretch receptors in the lung. So the pink puffer emphysematous patient, and then the blue bloater chronic bronchitic patient who is hypoxic, who has lots of sputum production, has cor pulmonale, hypoxemia. Although a lot of the patients with COPD have a kind of a mixture of both of these, so they're not pure emphysema or pure chronic bronchitis, but kind of a mixture of the two. So there's a lot of overlap of emphysema, chronic bronchitis, and in some instances asthma. So these diseases are not just very segregated and unique. There is quite a bit of overlap. But COPD involves a lot of different things: structural changes, inflammation, bronchoconstriction, all associated with airflow limitation. So again, bronchoconstriction may be partially reversible in many patients. They may develop airway hyperresponsiveness from smoking or other insults. And they do get chronic inflammation, just like they do in asthma, but the trigger is cigarette smoke, not usually allergens. The airflow obstruction can be irreversible because of fibrosis and lack of elastic recoil and destruction of the alveolar support tissues, or it may be reversible. Inflammation, smooth muscle constriction, and so again, it may be difficult differentiating COPD from asthma, particularly if they have a more reversible type of situation. The irreversible one is relatively difficult to treat, and a lot of these patients, they don't respond very well to bronchodilators, although antimuscarinic agents can be very helpful in these type of situations where it prevents dynamic hyperinflation and will relieve some of the dyspnea. Even though it may not improve their FEV1, it may decrease their hyperinflation. So antimuscarinics are really important in these patients. Structural changes, they get ciliary dysfunction, they get increase in mucus-secreting cells. That's why they have all that mucus. They get fibrosis in small airways, the destruction of alveolar walls and emphysema, and then they get vascular changes that can lead to pulmonary hypertension. So COPD really involves inflammation, bronchoconstriction, and structural changes. And diagnosis, again, a low ratio, less than 70%, smoker or history of exposure to a toxic inhalation, and a history of chronic bronchitis. And chronic bronchitis, the diagnosis is really pretty simple. You don't need a chest x-ray, you don't need PFTs for the diagnosis of chronic bronchitis. It's basically cough and sputum production on most days for at least 3 months of the year for at least 2 consecutive years. That's chronic bronchitis. And so that is more of a clinical diagnosis. So obviously smoking cessation is the big ticket in treating COPD. That's what causes the problem, and that's probably the most effective treatment. And with asthma COPD overlap, again, smoking cessation would be key and be the top priority in terms of trying to get people to quit smoking. We actually did a study looking at patients that came to a general medicine clinic who had successfully quit smoking, and we asked them, how did you quit? And it was interesting that 90% of the patients that successfully quit using cold turkey. They didn't use any pharmacological therapy. And so we thought that was a little unusual because all the national organizations, the American Thoracic Society, American College of Chest Physicians, American Cancer Society, all recommends first-line pharmacological therapy, whereas 90% of the patients actually quit by cold turkey. So we start to really emphasize at least trying cold turkey first, but before going to pharmacological therapy, which, you know, cold turkey has no cost and no side effects and can be very effective. So we want to try to prevent COPD exacerbations because they have a negative impact on quality of life. They accelerate lung decline. They increase economic costs. They increase mortality. And they impact symptoms and lung function. So we try to do everything we can to try to prevent them. COPD exacerbations, antibiotics, the cardinal symptoms would be increased shortness of breath, increased sputum volume and increased sputum purulence. And patients who require mechanical ventilations, antibiotics are generally recommended by the global strategy for COPD, GOLD guidelines. We know that non-invasive ventilation helps patients with COPD exacerbations, decreases mortality and need for intubation. Steroid therapy we do give in COPD exacerbations, generally is recommended 30 to 40 milligrams of prednisone a day for 5 days. It's discouraged to use more than 14 days of systemic steroids because of the increased risk of complications. So now let's shift to asthma, and I think you guys are much more familiar treating asthma, but just some interesting data on asthma. Of the people that come to a primary care physician's office, almost 60% of them, their asthma is uncontrolled. So I think that we don't identify very well patients that have uncontrolled asthma. And in fact, patients coming to the PCP for another reason, for a non-respiratory reason, but have a history of asthma, about half of those patients, their asthma is not controlled. And in patients surveyed in primary care physician's office that are asthmatic, about 1 in 3 adults with asthma were using albuterol at least once a day. And as we know, once a day use of albuterol would be moderate persistent asthma. And so a lot of patients are being uncontrolled with their asthma. And if a patient's taking albuterol on a daily basis, then they would require either step 3 therapy, either moderate dose inhaled steroid or an ICS-LABA combination. So low dose inhaled corticosteroid would not be an option for these patients that are using their albuterol daily. They would need step 3 therapy. So it's important to understand what are the risk factors of death from asthma to try to see if that patient's at risk of dying from asthma. You want to obviously be more aggressive. So if they're already on oral corticosteroids or they're recently been on it and still having symptoms, they have a difficulty time perceiving their airflow obstruction or severity. They have comorbid disease. So again, if they have asthma with COPD or asthma with heart failure or asthma with sleep apnea, they're going to have a higher risk of death. Serious psychiatric disease, psychosocial problems, lower socioeconomic status, illicit drug use. So even though asthma has a better prognosis than COPD, asthma with COPD has a worse prognosis than just asthma alone. This is a cut surface of a patient's lung that died from asthma, and you can see many of the airways are completely occluded by mucus plugs. This is a mucus plug completely occluding the airway. And then we have marked inflammation around the airways, inflammatory, and some of the airways are completely occluded with mucus plugs and inflammation. So this is what we want to try to prevent in terms of someone dying from their asthma, and this is the pathophysiology. If we look at the microscopic, here's a normal airway, a nice normal patent airway surrounded by alveoli, and then in fatal asthma, the airway basically is completely occluded. You can see submucosa, just millions of inflammatory cells, and basically overwhelming inflammation and basically complete obstruction of the airway due to an overwhelming inflammatory response. So I'm just going to give you a case here. A 35-year-old non-smoking female, history of asthma since childhood, comes in for a routine appointment. She wants a refill of her albuterol inhaler. She says it's working great. Her asthma is under great control. She says she uses her albuterol 1 to 2 times every day for wheezing. She wakes up 2 to 3 times per week with coughing, completely relieved with albuterol. She can't walk up 1 flight of steps due to shortness of breath. Vital signs and exam are normal. And so she says, well, all I want is a refill of my albuterol inhaler, and my asthma is under good control. Well, asthma is not that good control. Really, she has moderate persistent asthma. She's having daily symptoms. She's having nighttime symptoms more than 5 times a month. When we do her PFTs, we're going to find some significant obstruction. So it's important to recognize that many patients think their asthma is under control, but it may not be as well under control as they think it is. There's certainly different asthma control tests that we can use. This is the one that we tend to use, the ACT, to look at trying to assess whether the patient's asthma is in control or not. A score of 19 or lower means your patient's asthma may not be under control. So sometimes these objective tests are helpful to try to see whether the asthma is under control or not. Bronchoconstriction is obviously a big part of asthma. And this is before and 10 minutes after an allergen challenge. You can see the bronchoconstriction that occurs in the narrowing of the airway from just smooth muscle constriction, which is one of the causes of symptoms. And then the other is airway mucosal edema. This is an airway that's swollen and red from severe edema. And all the bronchodilators in the world isn't going to open up this airway. As you know, you're going to need systemic corticosteroids in order to overcome this inflammation. So when someone's presenting with an exacerbation, this is what their airway looks like. And it's just not going to get it done with beta agonist alone. You're going to need systemic steroids to manage this mucosal edema. Effects of inhaled corticosteroids and inflammation. And this inflammation we know can occur in asthma and COPD, certainly in the asthma-COPD overlap. But you have, this is before any treatment with inhaled corticosteroids, and you can see the epithelial layer is completely disrupted. There's no cilia here. The basement membrane is not intact, it's completely disrupted. And submucosa, you have all these inflammatory cells. So after 3 months treatment of an inhaled corticosteroid, we see same patient. Now the epithelial layer has regenerated. You have cilia, a normal epithelial layer, a basement membrane that's intact, and very few inflammatory cells. So even after 3 months of therapy, we can see anatomically a huge improvement in airway anatomy and function just with 3 months of an inhaled corticosteroid. Asthma action plan, this is what we use in our clinic for every patient, green zone, yellow zone, red zone. Strongly believe that all these patients should have the tools that they need to manage their asthma so they don't have to be calling or going to the emergency department every time they have an increase in symptoms. And so we do give patients with asthma, and we also have a COPD action plan. Also, we don't use peak flows for the COPDs, and peak flows may not be as predictive. It's symptom-based for COPD. And then in COPD, we actually have antibiotics in the red zone. But in asthma, this is the action plan that we use. And we've shown and studied this and published that we can reduce ER visits when patients have asthma action plan. So why do people have uncontrolled asthma? And one of the most important things is one of the most common reasons for not responding to asthma medications is the patient doesn't have asthma. It seems pretty obvious, but the patient has vocal cord dysfunction, heart failure, reflux, pulmonary embolism, sarcoid, pulmonary fibrosis, and many other things. Obviously, these things are not going to respond to asthma medicine. So the first thing that I always do is go back and say, do we have the right diagnosis? Do we have the wrong diagnosis? Do we have multiple diagnoses? Do we have asthma and one of these other things that we're not treating? And so I think that's a very important thing to go back to the beginning and make sure that you have the correct diagnosis and that you're not missing something that could be causing uncontrolled symptoms. Airway remodeling, we talked about, with untreated inflammation can remodel the airway, and now you're getting into a more fixed airflow obstruction and more into a COPD type of picture. And in that type of situation, we want to do more COPD type therapy with adding on antimuscarinic therapy in terms of trying to improve airway function. Persistent exposure to triggers. If a patient has allergic to cats and the cat sleeps with her every night, it's going to be very difficult to control her asthma if she's persistently exposed to something that she's allergic to. Lack of a controller medication, ICS/LABA. If they're not prescribed, the patient doesn't take it, they can't afford it, that obviously is going to lead to uncontrolled asthma or refractory asthma, which some people have and will respond to biologic therapy, which is another option in these patients. But obviously going through all these things first before we label them refractory asthma and move on to biologic agents. We know that low-dose inhaled steroids prevent death from asthma. This is data from Canada, where they have national health care, and everybody has access to medicine, but they obviously don't all take it. So here in a patient who doesn't take any inhaled corticosteroid at all, the rate of asthma death is significantly high. If they're taking their inhaled corticosteroid every month, the rate of asthma death is relatively low, and then if they're taking about half of the time, it's in between. So there is a definite correlation between use of or non-use of inhaled corticosteroids and death from asthma. So what about antibiotics for asthma exacerbations? Generally not recommended. If a patient has fever or purulent sputum, if they have pneumonia, or if they have suspected bacterial sinusitis, we'll give them antibiotics. And certainly in the asthma-COPD overlap, it's going to be a difficult decision to make. The smokers are more likely to get a bacterial infection. So these patients that even they're smoking asthmatics that tend to have purulent sputum and fever, I would be more prone to treat them with an antibiotic as opposed to a non-smoker with asthma exacerbation. So there may be some evidence for antibiotics in smoking asthmatics that have this asthma-COPD overlap. Spirometry testing obviously is very, very important, and we want to do that for both diagnosis and also response to therapy. So we've got the normal flow volume up here, and then we've got the classic obstructive pattern here. But pulmonary function studies, particularly with bronchodilator response, can give you a lot of information in terms of that patient, as well as eosinophil levels can also give you some information whether it's all asthma or all COPD, or is this overlap. So those things can be very helpful in trying to identify that. So how do we treat asthma-COPD overlap? So in the patients with eosinophilic COPD, and that's defined as either 150 or 300 total eosinophils, so we certainly want to make sure that they're on an inhaled corticosteroid in addition to bronchodilator therapy to reduce exacerbations. The impact study did show a reduced exacerbation, improved lung function and quality of life with triple therapy with ICS, LABA, LAMA. And so that's certainly an option in these patients, in these eosinophilic COPD patients. And then some biologic therapy is also shown to be important in patients that have more of this eosinophilic asthma COPD overlap, but there's been some evidence to support that. Smoking asthmatics, so that's kind of the other phenotype. The patient starts off as an asthmatic and smokes, and then develops COPD in addition to their asthma. Anticholinergics, so there's one study that looked at tiotropium reducing exacerbations by 21%, improved lung function and symptoms. Chronic azithromycin therapy to reduce inflammation actually was effective regardless of the eosinophil count, whether it was high or low. And then omalizumab reduced exacerbations with elevated IgE. And so those are all options in terms of therapy. So, you know, it does seem that there's, in this asthma COPD overlap, there's two kind of separate phenotypes. One is more of the smoking asthmatic, and then the other is more of the eosinophilic COPD patient. And so, but I think both of them are going to respond to anti-inflammatory therapy. Both of them are going to respond to antimuscarinic therapy. And then obviously, in both situations where you are continuing to have symptoms after you've ruled out other diagnoses, after you make sure that you're using their inhalers properly and doing spacers, then to consider biologic therapy. And I think that you know, there's been some really good articles. I think GINA guidelines has really good guidelines on when to use biologic therapy, but it really is a stepwise therapy to rule out the other, you know, more simple things like non-compliance with medication, not using inhalers properly, not using spacers. So all those things need to be addressed first before we jump into biologic therapy. You definitely want to avoid long-acting beta agonist monotherapy. There was a SMART trial done, it was back in the 80s, where they treated asthmatics with monotherapy with Ceravent, a long-acting beta agonist. And in asthma, there was a definite increase in mortality, which is really important. And so if you have somebody with asthma-COPD overlap, you don't want to give them monotherapy with a long-acting beta agonist, as it may increase mortality, and that was borne out in that study. So that should not be given. It was kind of a bizarre study. I was asked to participate, and I declined. I didn't like the way the study was set up, and we already knew at that time that short-acting beta agonists given on a regular basis increased mortality, and so it was not a big stretch to predict that long-acting beta agonists as monotherapy was going to increase mortality. So I declined to participate in this study, and I'm glad I did. It really wasn't a very good study, but it did identify a danger of giving LABA monotherapy to asthmatics. What about intermittent asthma-COPD overlap? Patients with only symptoms, say, from a viral infection or allergen or irritant. And so, here's where my management differs from the GINA guidelines. The GINA guidelines talk about Symbicort given on a PRN basis. So the more symptoms, the more Symbicort you take, and the more anti-inflammatory you get, which certainly makes sense from a pathophysiological standpoint. The problems I have with the GINA recommendations of PRN Symbicort is that it's not FDA approved in the United States, and in fact, on the package insert for Symbicort, it says not for use for acute symptoms, only for preventing symptoms. And so that causes me some pause in terms of medical legal exposure of using a drug off-label, and also it completely goes against what they're saying in the package insert. So my approach to intermittent ACO and also intermittent asthma would be to use an ICS LABA, like Brio daily or Advair or Symbicort twice a day, as directed, as indicated, for a full 2 weeks in the action plan. So in the yellow zone, when they start having symptoms from a viral infection or allergen, I'll put on their action plan to go ahead and take their ICS LABA, their Symbicort, their Advair, or their Brio every day for 2 weeks. And then with a PRN, either albuterol alone or albuterol ipratropium. For asthma-COPD overlap, I like to use Compavent as their rescue, because I think it works a little better than albuterol alone. And I'll do that for a full 2 weeks, like in the action plan, 2 weeks on a daily basis, which follows the recommended doses for the ICS LABA. And I think that it relieves their symptoms, and oftentimes is very effective at bringing them back down to baseline. And so you don't have to give the ICS LABA, year-round or on a daily basis. You can just give it when they have increased symptoms. But instead of on a pure PRN basis, I would do it on a daily basis for a full 2 weeks in their action plan. So that's kind of one of the differences I have in my management, different from the GINA guidelines for both intermittent asthma and intermittent ACO. I will do it this way in their action plan instead of on just a PRN basis that they decide when to do it. Once they are having symptoms and are requiring this, I will have them continue it for 2 weeks. And then there is some data that shows that, and to get optimal effect from inhaled corticosteroids, it takes at least 2 weeks of therapy of inhaled corticosteroid to get optimal. You're going to get some improvement, but it's not the optimal anti-inflammatory effect until at least 2 weeks. So that's how I approach these intermittent ACO patients as well as intermittent asthmatics, a little different than the GINA guidelines. Obese patients, they generally will have more severe symptoms and more refractory obstructive airway disease, both COPD and asthma and ACO. Oftentimes they have resistance to beta agonists, just like they have insulin resistance. And so short and long-acting antimuscarinic anticholinergic agents are very effective in these patients. And so I will early on start these antimuscarinic agents, either long-acting for maintenance or short-acting for acute relief. And a lot of these patients will say, yeah, albuterol doesn't work for me at all, but when I use Atrovent or when I use Compavent, it does improve my symptoms. So that is something to keep in mind in obese patients. So goals of therapy, as we talked about, so in asthma, my goal is normal lung function. I would like to have their PFTs normal with no bronchial reactivity, because the more reactivity they have, the more inflammation they have. And if they can go up by 30% in their FEV1, then if they're exposed to an allergen, they can go down by 30%. So my goal in asthmatics is to have normal lung function and no reactivity on therapy. Rare symptoms, no activity limitations, and no exacerbations. This is pretty high expectations, but I think that this is doable in the majority of asthmatics, and sometimes it takes biologic agents to get there. But this is my goal for asthma, and I think that it's achievable, and I'm aggressive at doing therapy until I get to these goals. COPD is a little bit different. And COPD, you're not ever going to get to normal lung function and rare symptoms. So the COPD, our goal is to reduce exacerbations. You know, exacerbations can contribute to worsening of lung function and increased mortality and morbidity. So reduce exacerbations. And then we want to improve symptoms, but we're not going to be able to make that patient completely asymptomatic. So and then ACO, so where's our goal there? Probably somewhere in between. And then again, if they're more, the phenotype's more closer to asthma, I'm going to be closer to these goals. If the phenotype's closer to COPD, they're going to be closer to these goals, but it's going to be somewhere in between there. But this is one of the big reasons I think it's important to try to distinguish asthma from COPD, because the goals are quite different. And if the patient has COPD and I'm using these goals, I'm never going to get there. If the patient has asthma and I'm using this goals, then I'm undertreating that patient. So I think it's important to differentiate it if you can. And then if you can't, and it is asthma COPD overlap, then again, you're going to have to kind of sway whether you're more phenotypically asthma or more phenotypically COPD when you're looking at the goals. Okay, so there's my references. And I'm happy to answer any questions.
Thanks, Dr. Salzman. Let's open it up to the group for any questions, please. All right, while they're thinking, I'll throw in one thing. We talked about the effect of smoking on the overlap syndrome as well as COPD. Where does pollution fit in that? As our pollution levels are going higher and higher year after year, we're trying to do a lot of things to reduce it, but I suspect pollution plays a big part in this too.
Oh, it does. It does in chronically, in terms of when you look at cities in China, they have much more COPD and chronic bronchitis. Several years ago, they had an exhibit here in town where they had all these bodies, that were shown, that was kind of an artistic thing, and a lot of them were Chinese individuals. And when you looked at their lungs, all of the lungs had all this carbonaceous material in the lungs. It was pretty impressive. I mean, I just noticed it, because they had, these are the lungs, and they were, really filled with carbonaceous material from all the pollution from living in big cities in China. But yeah, I think the pollution not only contributes to chronic bronchitis and chronic symptoms, but also will contribute to exacerbations. And there have been studies when the pollution levels are up and when the air is poor, that there's more exacerbations for both asthma and COPD. So that is a risk factor for exacerbations and also for chronic disease and chronic bronchitis from pollution. So that does play a significant role. And if you have an asthmatic that's continually exposed to a high pollution city, they will develop the ACO, asthma COPD overlap, from the exposure from pollution.
Yeah, I just saw an article this weekend about particulate matter 2.5 and its association with inducing genetic changes. So the end result, potential for more cancer along the way too.
Yeah, right. About lung cancer, yeah. So there's a lot of problems with all the pollution we're seeing, and we're going to see it in cities like Beijing and other cities that are have horrible pollution. Los Angeles, particularly with all the fires they've been having, that's going to play a big role too.
Certainly. Another question / comment. You showed us the lung function decline. Kind of as we age, we're all going to start to lose lung function. But obviously, with the COPD that are currently smoking, it's significant. If they stop smoking, it improves a little bit. If you look at our asthmatics in general, the idea is they're reversible, although I tend to see a lot that are less reversible over time. And then, could you comment on the overlap syndrome, and if they follow the same decline as the COPD, or are they somewhere in between, like an asthma / normal decline?
So it's interesting, and this goes back to the Dutch hypothesis. If you got somebody that has childhood asthma and it's not very well controlled, and they get to be an adult, and now their lung function has already declined, say, by 20%, then they start smoking, and then they have even more of a decline, they're going to develop COPD much sooner than someone who never had childhood asthma and started off with normal lung function before they started to smoke. And so just the fact that you've had childhood asthma and maybe it's not well controlled, your lung function is starting at a lower level, then you start smoking, then your COPD is going to come on sooner, or you're going to have a higher incidence. Whereas the patient that didn't have childhood asthma maybe smoked, but never really will develop enough lung obstruction to have COPD. So that is probably the biggest issue. But in terms of asthma and COPD, obviously, if you've got two things affecting your airways, both COPD and asthma, that smoking is probably going to cause even more of a decline. But I don't think that's been studied and looked at, because it's kind of a new concept. So I don't think there's been any studies on that.
Thank you. Do we have any other questions from the crowd? Okay, it looks like all's quiet today. So Dr. Salzman, we appreciate you giving this new presentation to us on the asthma COPD overlap syndrome today.
Good. I hope that you guys learned something. All right. Good luck.
Okay, thank you so much. Appreciate it.